Thank you, everyone. We will be letting people in very quickly. So we'll give 1 minute. And si vous parlez le français, il y a l'interprétation ci-dessous de Zoom. So if you want French, there is the button on the bottom for French. And excuse my French. Wonderful. So people are coming in. We're excited to start this webinar today. Esteemed colleagues, good afternoon, good evening, good morning. My name is Lisa Hilme, Executive Director of Core Group, and I'm also a nurse. As I mentioned, si vous parlez le français, il y a l'interprétation ci-dessous le Zoom. We are so excited that Core Group and Gavi, the Vaccine Alliance, are pleased to welcome you today to an important webinar on reaching zero-dose children in fragile states and cross-border populations in Africa. Thank you so much for taking your time today. I know we're all busy. Today you will hear about the zero-dose immunization program, or ZIP, and we will feature speakers from Gavi, the Vaccine Alliance, International Rescue Committee, or IRC, and World Vision. We will also hear from the Core Group Partners Project, and please note their name, they just changed it. And we'll hear how they have developed strategies on reaching fragile states in the Horn of Africa, as well as cross-border populations and strategies that they've used. Countries across the Sahel and in the Horn of Africa have been facing compound risk of climate change, food insecurity, poverty, and often conflict. And the resulting impact has really impacted security, livelihood, and it's driven sometimes internal displacement and migration across border. And in such fragile states, identifying zero-dose children, or ZDC, and missed communities, and really reaching them with routine immunization, it's one of the most powerful interventions for reducing under 5 mortality and morbidity and improving health. And we also know from the recent WUENIC report that WHO and UNICEF publish on country estimates for vaccination coverage, the coverage has continued to decline in 2021. And we have 25 million infants that have missed out on life-saving vaccine and missed out on 1 or more doses of DTP through routine immunization in 2021 alone. So this webinar will be an opportunity to learn more about the ZIP program and hear of other strategies that CGPP applies. Through the webinar, you will hear about ZIP and how the ZIP program is not just about zero-dose children, that the populations that this program, the ZIP program, serves is really about populations systematically beyond the reach of government health services. And how through Gavi's investment, this ZIP program is prioritizing different populations in different contexts beyond their other funding modes. And it really is looking at new ways of working and novel approaches. So we're so happy that you're able to join us on this learning. We'll be learning together, and this is going to kick us off on this fabulous journey. As I mentioned, I'm a pediatric nurse. I've worked on many mass campaigns, immunization campaigns in Africa and Asia. And we know that ultimately we want to get the shots in arms. And it's a very complex situation. We need innovation, we need collaboration, and progress to scale. So thank you very much for this new model of working and for your investment to Gavi. We also want to thank the USAID-funded CGPP program of 23 years, whose Secretariat Directors and Ellen Ogden of USAID just received Lifetime Impact Awards. So congratulations on your very important work. This is, can you please mute? Thank you. This is an interactive event, so please introduce yourself in the chat. where you are from, what organization. Please ask questions in the chat box. We will be keeping track of it. Comment, and we will be calling on you later for questions. We want to hear from you. We will show you a short animation developed in conjunction with Gavi, our colleagues at Medical Aid Films, that you can use this in your programs, and it will be translated in French, Swahili, and Arabic for a new campaign in the coming weeks. So look more for that. And our colleagues will put the link to the animation in the chat box. And then I will turn it over to Naomi Senda, Core Group's Communication and Knowledge Manager based in Nairobi, who will be our distinguished moderator. So thank you very much to all of you, our esteemed speakers, and let's show the animation right now. Thank you.
Of the power of vaccines. Yet, despite years of progress, millions of children worldwide still miss out on basic vaccinations. Zero-dose children who haven't had a single dose of the most basic vaccines increased to over 17 million. Effective immunization programs are fundamental to reaching them. They also help overcome gender differences by giving girls and women equal chances to access primary healthcare services. Reaching communities with immunization also increases access to other essential services like nutrition, water, and sanitation. By working closely with these communities, we can reach the target of halving the number of children with no vaccines by 2030. And by reaching these zero-dose children, countries can help them to live a healthy and productive life. Together, we can ensure that no child is left behind.
Thank you so much. That is the animation that Lisa had mentioned earlier, and we will be translating it into French, Kiswahili, and Arabic, and hopefully share it with you for you to use in your advocacy for reaching zero-dose children. At this juncture, I will introduce our esteemed speakers for this webinar and begin with Victor Reynard. Victor, just give me a second. Victor Reynard is a senior manager, equity and zero dose, leading the zero dose immunization project at Gavi. He has a master's in development economics from the London School of Economics and a bachelor's in political science. Prior to joining Gavi, he worked in DRC on a strategy and implementation of the Mashako Plan, and before that, he worked with Oliver Wyman and the Ministry of Foreign Affairs in France, and has also held other policy, analytical, and strategic roles. He has worked both in private and public sectors on the design and implementation of development strategies. Thank you so much, Victor, for joining this webinar. Our next presenter is Dr. Foyetu Eugene, who's a sociologist and market for health expert in Cameroon. He currently works with the Cameroon Baptist Convention Health Services as a country manager for the Race for Sahel project, where he also serves as the health policy advocacy advisor. He has technically piloted the creation of the Christian Health Associations of Cameroon, which federates major faith-based healthcare providers in Cameroon. With his extensive research in policy advocacy and lobbying, he has been operating as a health advocate in Cameroon and the larger Africa. Thank you so much, Dr. Eugene, for joining this forum. Our next speaker will be Dr. Paul Kisia, who's the technical lead and immunization advisor for the IRC Gavi REACH project. Dr. Kisia is a public health professional and has worked in various capacities in various organizations. He has a broad program expertise in HIV care and treatment, reproductive, maternal and newborn health, child health and immunization, public supply chain systems, and community health systems. He holds a bachelor's degree in medicine and surgery and also has a master's in public health. Our final presenter for the day will be Mr. Ahmed Arale, who's the Deputy Global Director for the Core Group Partners Project, where he provides technical direction and assistance in continuous program quality improvements, quality control of partners, and he previously worked at the project as the Secretariat Director for the Horn of Africa, where he provided technical leadership in all aspects of project planning and implementation, and also the coordination and collaboration with key partners and stakeholders like the Ministries of Health and Agriculture, USAID, UNICEF, WHO, and Rotary International. Mr. Ahmed holds a Master's of Public Health from the London School of Hygiene and Tropical Medicine and a Bachelor's of Nursing from the University of Dundee in Scotland. He also has a higher diploma in Health Systems Management from Galilee College in Israel. Thank you so much to our speakers for joining this conversation. Just a reminder to everyone that this webinar is also available with French translation. You can find the link for interpretation at the bottom of your screen. And as the presenters make their presentations, please engage us with questions and comments on the chat box, and they will get to you after the presentation. So I'll introduce our first speaker, that is Victor Reynaud. Thank you.
Thank you, Naomi, and thank you. It's a pleasure to be here to talk about the ZIP today. So the zero-dose immunization program, ZIP, is one of the strategies to reach zero-dose children launched by Gavi last July. To understand ZIP, the ZIP project, let me start with some background. So although the number of zero-dose children has declined by 50% between 2000 and 2019, this progress was disrupted by COVID-19. The prolonged disruption to routine immunization during the C-19 pandemic has resulted in an increase of 3.2 million zero-dose children in just 2 years and a half, an increase of 34%. When discussing about zero-dose children, it is useful to frame the issue we are trying to solve for in a way that is helpful for the alliance, countries, and partners. One key criteria when thinking about zero-dose children is whether they live within or beyond the reach of national health systems. Most information and data we have currently cover zero-dose children living within the reach of the health system. This could be only the tip of the iceberg. What about the zero-dose children that live beyond? Next slide, please. As part of our 5.0 strategy, Gavi puts the equity goal of leaving no one behind with immunization at the center stage. In addition to refocusing country support through health system strengthening, targeted country assistance, Gavi set aside a $500 million fund to specifically target zero-dose children. This is the Equity Accelerator funding. $400 million are going through government to support their efforts in reaching zero-dose children that are located within the reach of their national health systems. The zero-dose immunization program, the ZIP, has a 100 million envelope to target zero-dose children that live beyond that reach. Both envelope, EF Core and ZIP, are essential and complementary to successfully reach the equity goal. Next slide, please. ZIP is nothing less than a paradigm shift in Gavi's approach to unlock these zero-dose children that have been systematically missed. We have covered the rationale and what ZIP is aiming to achieve. We have also looked at who ZIP is aiming to reach. Let's look at the how. Gavi Independent Review Committee has selected 2 INGOs, World Vision and IRC, with a strong footprint in these settings to address last mile delivery. ZIP is taking a regional approach to solve issues like displaced and nomadic population. Both World Vision and Rescue are leading consortia with state-of-the-art expertise and innovation. We are also leaving a one-size-fits-all approach to tailor the needs of each specific population and context. And last but not least, we put the monitoring and evaluation at the center with real-time data collection system to manage and monitor the project. Through the WUENIC, World Vision is covering 7 countries in Sahel, while the IRC 4 countries in the Horn of Africa. ZIP is also a great opportunity to learn about this population. According to UNHCR, ZIP population has already reached the 100 million mark in 2022 and will keep increasing. We need to be able to learn and reach this population. The data, as we have seen, is limited when it comes to the specific set of zero-dose children that live beyond the reach of national health systems. We have many questions, such as how to identify, track, and reach this population. What does sustainability means in those contexts? And we are very excited to be able to count on the IRC and World Vision to support the Alliance in answering many of them. Thank you.
Thank you so much, Victor. Naomi, over to you as moderator. Okay, interesting. So seems somehow Naomi, it was kicked out of the meeting. So as she is getting established, we will remind everyone again that there is French translation on the bottom. And, Victor, I thank you so much for your presentation and the investment for this important program in ZIP. We're just going to wait 1 second while we have Naomi getting up on board, but I'm wondering in the meantime, excuse me, as we look at the ZIP program, how do we really know that the program can support the governments also in addressing how to reach zero-dose children?
Thanks, Lisa, for the question. I think the aim of Gavi's fundings and different levels is always to strengthen a government's toolbox. Governments need different tools to be able to face a different population and context. So Gavi is supporting government directly with HSIS, with HSS, so health system strengthening, specific technical assistance, EF Core with a 400 million envelope that targets specifically zero-dose children. For areas where the national health systems does not reach, governments have now ZIP, and ZIP is complementary to all of the already existing approach. That begs the question of sustainability for ZIP. ZIP is going to be implemented in different contexts, and based on the very specific context and the population, some of the areas for which ZIP will be and is currently being implemented will return to the national health system coverage in a short while. It depends on the situation, basically, but we need to be flexible and to only be complementary to where the government is. Over.
No, thank you very much. And we know that many governments, they say they are in control of their government, but in the reality, sometimes those areas are just beyond the health services. So this is such an important investment. Can I ask you, I know that Gavi's been working very hard and over the past several years with civil society in developing a civil society engagement strategy. So can you maybe speak to what made Gavi shift its approach and start collaborating with NGOs and civil society?
I think this shift in Gavi and also the Alliance is something that we need to be thankful for. I think a couple of points. We have seen a stagnation of coverage rates around the world. The C-19 pandemic drastically increased the number of zero-dose children. I think there was a need to act and to act swiftly. The grassroots community level engagement is key to unlock these zero-dose children, and civil society organization, NGOs are key actors, but once again, it's not like one or the other, both are complementary. And we need all the tools in the toolbox to be able to reach as many children. Over.
No, thank you very much, Victor. And thank you for your willingness to work with civil society and NGOs. Sometimes they are the only ones that have this trust. Can Mercy please mute yourself? Thank you. Or may the moderator please, the host please mute her. Thank you. And one more question I see in the chat box from Krishna Nupane. They're very excited about the ZIP program and wondering, what about South Asia and what's the investment look like in the future in South Asia for these very important collaborations?
That's a really good question. Basically, the goal of ZIP is to reach zero-dose children that live beyond the government's or the national health system reach. It's also to gather key learnings. With those learnings, we'll be able to unlock zero-dose children in other areas, in other countries, with settings that are similar or with population that have been systematically missed. So of course, for the next Gavi strategy, the goal would be to expand if we are successful, and we will be successful, to other part of the world.
Thank you so much. And I know this, the learning from this is just so important. So I hear that Naomi is back. And so I will turn it over to her. We are getting lots of questions in the chat box. We'll take those, but we'll continue to move through our presentations and then have wider questions. So Naomi, back to you.
Thank you so much, Lisa, and thank you, Victor, for your presentation and for sharing that information. We move to our next presenter for this webinar. That's Dr. Eugene Foyet, who will be presenting about the Race for Sahel project. Dr. Eugene, the floor is yours. Thank you.
Thank you, Naomi. The entire community of humanitarian actors is really grateful to Gavi for this mechanism. In the Sahel, especially, where we have multiple crises affecting, deteriorating our social and health system. So I'm Dr. Foyet. I will be presenting, on behalf of the Sahel team. And a slide. So the race for ZDC Sahel, as Victor already mentioned, is a 4-year project funded by Gavi to identify and reach zero-dose children in 7 countries in Sahel. Et dans le cadre de cette présentation, je voudrais d'ailleurs, sachant que la plupart des pays sont francophones, parler en français pour exprimer vraiment l'idée qui est derrière ce mécanisme de Gavi. Donc, le consortium qui pilote le programme pour lequel au Cameroun nous sommes partie prenante, c'est World Vision, et qui dans le même consortium implique Food for the Hungry, Zenensis, Core Group et ACHAP. Et donc, au Cameroun, l'initiative est portée par les œuvres de santé de la Convention baptiste camerounaise sous l'entremise de l'Association chrétienne de santé africaine, ACHAP. Et donc, ACHAP, c'est une grosse organisation internationale qui est basée à Nairobi et qui est une plateforme des organisations chrétiennes qui couvre plus de 34 pays et dont à peu près 43 associations de santé. Next.
Yes, and if you can pause 1 second, Naomi, can you make sure that the English translation is working? Thank you. Attendez, Dr. Foyes, s'il vous plaît, un moment.
Thank you, Lisa, but I can continue in English. I just wanted to, ensure that my views are really, my points are really important by, the large members from Sahel who are mostly English French speaking. So, qu'est-ce qui fait la particularité du Sahel? Vous verrez que nous avons en exergue des questions liées au conflit et nous avons une porosité des frontières qui complique davantage la situation dans le Sahel. Next. Donc, vous verrez par exemple pour le cas du Cameroun, vous verrez que dans le cadre de notre pays, il y a une multiple crise qui affecte le pays, dont dans sa partie septentrionale, au niveau de l'extrême nord, avec la secte de Boko Haram qui paralyse carrément toute la région du Nigeria, du Niger, du Tchad et du Cameroun. Et puis, on a au niveau du flanc ouest la crise séparatiste qui cumule avec la crise au niveau sécessionniste, au niveau du Biafra, pour former un grand pôle d'insécurité. Donc, dans le flanc est, vous verrez qu'il y avait la crise politique au niveau de la République centrafricaine. On a beaucoup d'intuitions qui frappent notre flanc est et donc créent une multitude, n'est-ce pas, de personnes internement déplacées et accentue donc de ce fait les déplacements forcés des populations. Donc, vous verrez que 80% des districts que nous avons ciblés dans l'extrême nord, dans le sud-ouest, dans l'ouest et dans le littoral de notre pays sont fortement affectés par les questions de crise sécuritaire, notamment les 3 régions qui sont affectées par les crises sécuritaires. Et donc, les régions telles que la région du littoral sont fortement affectées, n'est-ce pas, par des personnes internement déplacées et d'autres situations indirectes liées à cette crise. Donc, 65% de ces districts-là partagent les frontières avec les pays que j'ai cités tout à l'heure et on se rend compte que toutes ces régions que nous avons sélectionnées, n'est-ce pas, pour être bénéficiaires de l'appui de Gavi, sont des régions qui abritent des communautés nomades qui sont généralement difficiles à toucher par l'État avec les autres mécanismes ordinaires. Donc, 50% carrément sont des populations, des populations réfugiées. Les populations réfugiées des camps sont faciles à gérer. Dans le cadre de notre initiative, nous sommes rendus compte que les populations réfugiées qui sont disséminées dans les populations reculées sont les plus difficiles à toucher. C'est pour ça que nous avons pensé que dans le cadre de ce mécanisme, il serait important de mettre un accent là-dessus également. Next. Donc, vous verrez que suivant cette nomenclature des urgences, nous avons mis en relief la région de l'extrême nord, les régions du nord-ouest, du sud-ouest, comme je l'ai cité tout à l'heure, vous verrez que la couverture en penta est également pas assez considérable et du coup, le nombre de zéro dose également est très, très important. Donc, ce mécanisme viendra aider à renforcer la couverture dans ces régions-là et nous permettre de toucher les enfants les plus vulnérables qui sont, n'est-ce pas, laissés pour compte par tous les autres mécanismes ordinaires. Next. So it seems English translation is not working. So I'm trying to explain. Let me summarize it briefly. In our country, for instance, we are going to focus this response, this mechanism in 4 flash points in our country, most affected with security issues. We have the far north, the northwest, the southwest of our country. In the far north, we have
Excuse me, sorry. Naomi, excuse me, everyone. I apologize for this. Naomi, can you please make sure the translators button is switched over, because we can hear him for everyone. Thank you very much. And we apologize, everyone. These glitches sometimes happen. So Phil, hopefully you are now only on the French channel, and we will resume. Thank you very much.
Ok, merci, merci Lisa. Donc, le contexte humanitaire est là. Nous sommes dans le cœur du lac Tchad et vous voyez avec toutes les insécurités qu'il y a aux alentours, il est important de mettre l'accent sur, n'est-ce pas, les approches avancées pour que ces enfants-là soient également touchés. Donc, jusqu'en décembre 2018, nous comptabilisions 34% des formations sanitaires dans, n'est-ce pas, ces régions-là qui n'est-ce pas, ne fonctionnaient pas normalement. Et donc, on voit bien qu'au fur et à mesure que le temps passe, la situation ne fait que s'exacerber, notamment avec les changements climatiques qui créent de temps à autre les inondations qui compromettent, n'est-ce pas, les efforts du système de santé pour, n'est-ce pas, toucher effectivement les autres pays, les régions, les aires de santé les plus affectées. Next.
Phil, I'm sorry, but you are still being heard in the English. Naomi, can you please fix this? And Foyet, please maybe just pause a second. Yeah, thank you. We apologize for this. Naomi, if you can please fix that. Thank you.
It's been done. Phil, can you please speak so we can confirm if you're still being heard on the English channel?
No, but we're hearing him. We're hearing you all over. So why don't we just make sure that he's in the French and Foyet, if you can please continue. Thank you everyone for your patience. Thank you.
Thank you. So may I just continue in English?
Yes, please.
Yeah, it's possible.
Thank you. So I will just continue in English. I hope, I mean, it's not like hoping, but I'm sure we will still meet the same expectation because there's French translation. So as far as Cameroon is concerned, around supply side, currently around 11% of our health facility, are not, offering vaccination services because of all these reasons that are presented, and 24% of this facility are not able to, have acceptable functional cold chain system, because of those multiple crises. 19% of vaccination sessions, as we discover, In these three regions, we identified were not conducted due to the fact that the health worker could not just organize outreach services. And then we have discovered that accessing special populations such as pygmy refugees remain very difficult to the normal routine system. And around demand sites, with the COVID crisis, we discovered that vaccine reticence has become another major threat to immunizations that we need to be considered, including in those hard to reach places. So the link between the health services and the target population, are being discontinued because of shootings here and there, and because of also a health worker refusing to work in difficult places, preferring to establish where at least they can get their kid go to school, at least where their life will not be threatened. But we have discovered that some socio-cultural issues are also, increasing all these challenges in the regions where we are going to focus our response. So we feel all these combinations of issues at supply and demand side really need to be addressed to, ensure that we effectively complement the effort of the state to reach where those children in places that are not, actually properly covered by routine mechanisms. Next. So how are we going to do? We'll be leveraging on many mechanisms to ensure that this is properly done. Next, we are going to ensure that we leverage on the large Fed network that we have constituted in Cameroon, providing all the service in all the 10 regions to ensure that at least we reach effectively these communities. We will be stimulating community opinion holders to fully play their role and to become vaccine champions. And of course, we strengthen their skill to be able to, provide, to conduct demand creation. And then, of course, we are going to work with the Christian Health Associations of Cameroon that was established, which is representing close to 40% of workforce and with 35% of health facilities. And we are also going to, intensify advocacy towards the councils to ensure councils also play their expected role in building, equipping, restoring health facility, and also engaging communities where the central level state is not able to provide services effectively, at least to demonstrate some level of ownership to confinance health facilities, because we discovered that these crises are also coming in a situation where community participation to healthcare was also very weak. And as we are going to be building sustainability as well, we will be strengthening the capacity of health dialogue structure to also mobilize the community to also contribute to disease preventions in their community. So overall, dear colleagues, community of actors, that's how a bit in the Sahel regions, the various countries, the various implementing partners are planning, strategizing in collaboration to the state and other EPI stakeholders to, complement the effort of the states where the need is the most. We want to ensure that these equity accelerator funds truly benefit the people who need it the most. And we will be doing so by also building sustainability such a way that at the end of the day, there should be functional mechanisms in those places where we are going to be working, that we continue, bridging the gaps even after our response. So that's what I could provide as a few points as far as Sahel is concerned. We want to thank you, core group, for this opportunity to present the overview of our response.
Thank you so much, Dr. Foyeth, for that presentation. And once again, apologies for the hitch with the translations. We've gotten quite a few questions in the chat box, and I see your colleague Epi is tackling a few of them, but I will ask one here. Gail is asking, what is the reason that we only have, what is the reason for 19% of the vaccination session planned out not being carried out?
Thank you, Naomi. The health districts, when they plan to organize outreach activities and in health areas, definitely they will prioritize where the access is, most favorable. Definitely, when there are shootings and when the terrain, the topography is complex, too often they will just put on hold. And because as well, the health districts are having a lot of needs in terms of logistic needs, and they are not having bikes, appropriate vehicles to, go into some communities that are, most remote. And also, many other issues like kidnappings, when some of those outreach campaign or activity are planned, definitely they remain in plans because the community health worker or the team from the health facility cannot effectively, reach the community where those activities were planned. So we are working in we are talking of different, very difficult contexts where sometimes just to cover 5 kilometers may cost a lot, including human life. So those are some of the reasons that are affecting health areas and health facilities not to be able to conduct all their planned immunization services.
Thank you, Dr. Eugene, for even giving us a look into how fragile or how difficult the contexts are. You spoke about your plans or your strategies for community engagement, but can you please tell us what your strategies for surveillance are that you'll be applying in identifying and reaching these zero-dose children in the fragile contexts?
Thank you, Naomi. We are very happy that this response, the way in its configurations, has taken into account those areas of needs. So we will be working closely with Zenensis, Tech. We will be working closely with Food for the Hungry core groups, and of course at the country level, we are going to align with the mechanisms, the hit and run approach to covering the hard to reach places and the insecure places, not only, but we will leverage on the work already conducted by other partners as CHAD to ensure that all the early alert mechanism at the district level following the already established strategies in country are being enhanced. We are simply going to complement the efforts of the health district to effectively reach those health areas that are of difficult reach, and ensuring that in places with no partial access or the places with very limited or no access, we leverage on some other systems, traditional systems, to ensure the services, are being provided. Of course, we will stimulate and revitalize the dialogue structure to ensure effective tracking and follow-up, to ensure at the same time that services rendered are properly documented and reported back to the health regions and to the health services, because we are working in Cameroon in the context of service delivery point, one reporting tool, and then one data flow. So that is a bit how we are going to formulate our response in Cameroon. We leverage mostly on coordination, because it was formally prescribed by our health authorities not to implement these ZIP initiatives as a separate farm mechanisms, which is not connected to the overall strategies to reaching a ZDC in Cameroon. So by so doing, we will also be implementing most of the strategies that are already provided in our strategic document in country. So thank you.
Great, thank you so much for your responses. There's other questions that are being posted on the chat box. If you could respond to them. We've heard about the strategies to reach the zero-dose children in fragile and cross-border context in the Sahel region. Now we move to the Horn of Africa region and welcome our next presenter, that is Dr. Paul Kisia. Paul, coming next.
Yes, good afternoon, good morning, good evening, colleagues. So I'll be presenting on behalf of the Gavi project that's implemented in the Horn of Africa, just to share our experiences. I work as the technical lead and also the immunization advisor for the project. Next slide. Yeah, this REACH project, Gavi project, has been funded to the tune of $50 million. And we started implementation from July to all the way to December 2025. But there was a period of 3 months during inception. And the aim of this program, just like has been said by Gavi colleague and Rice Sahel program, we are seeking to reach the zero-dose children and mixed communities within this context of fragility, conflict, or cross-border settings in Somalia, Ethiopia, Sudan, and South Sudan. During the inception period, we focused more on really generating evidence that will enable us understand these zero-dose children, where they are located, and some of the issues that are leading to them missing out on immunization. Overall, we have about 19% of the children who have been unreached. Either they are under-immunized or purely zero-dose. 19% of those children globally are found within the Horn of Africa. We are now in the implementation phase, and we are looking forward to learning as we improve, as we seek to identify and reach those children, and of course, at the same time, using evidence to put in place systems that will be sustainable beyond the life of the project. Next slide. Yeah, so through the evidence report, we've been able to look at the available data, and we used data from different sources, including talking to various stakeholders, Ministry of Health, using administrative data, as well as IHME data. And we noted that about 6.8 million children are found within the Horn of Africa. They are under 5 years of age. Out of those, an estimated 1.86 million children under 5 have actually not received a single dose of antigens. And we have about 116 locations that we are focusing on. These are locations that we have identified that have a substantial number of the zero-dose children. Once again, the locations identified based on the criteria that the regions who are to be in conflict areas, either cross-border settings, they have internally displaced people, or have other constraints that are leading to the children being under-immunized. Some of them are actually in conflict settings. Over 90% of the locations are actually in the conflict settings. About that 9% are nomadic, people moving from one region to the other, moving across borders for different reasons, are consequently missing out on those vaccination services. About 15% are actually internally displaced persons. We have refugees, taking about 24% of the locations you are operating in. Then we have areas that are state-controlled with others that are partially controlled. And this has had implication on continued access and utilization of the immunization services, consequently contributing to some of them being left out. Then we have about 6% of the locations being in areas that do not have a state control. Looking at the map, you will see that we have identified locations with color-coded, either green, orange, or red, from Somalia to Ethiopia to South Sudan and Sudan. From the evidence report, we noted that there are different access constraints in those areas. Some of the locations that have zero-dose children are currently accessible, so they are colored green. Others are partially accessible, so they are colored orange, and red ones are inaccessible as of now. This just points to the magnitude of the challenge within the Horn of Africa. But of course, as we move forward, we'll be negotiating access to some of the areas that are actually inaccessible to ensure that we reach those children with immunization services. Next slide. So we will be contributing to the broad Gavi goal of reaching these immunized children. And we have strategies to enable us identify and even quantify these zero-dose children. We want to understand their geographic distribution, the locations there, where they are, some of the barriers, whether supply side or demand side, that are contributing to them being unreached, and also other characteristics of importance that will enable us be able to reach them. We are negotiating access, of course, putting in place strategies to address those barriers. This could be supply or demand, and ultimately we want to increase coverage among those under-vaccinated communities. We'll be using data in our planning, our decisions. We'll collect this data, we'll analyze, and we shall use it to inform our learnings as well as strategies to reach those under-immunized children, and inform advocacy with the various stakeholders so that these groups can be prioritized and considered in the various plannings by those stakeholders and the governments. Next slide. So what are the broad strategies? Having shared some of the characteristics of the context in the Horn of Africa, the key strategies we are adopting include displacement tracking and monitoring. You want to look at the movements of the populations across the border for whichever reason, whether it's conflict, whether it is nomadism, or whichever reason, you'll be tracking those displaced communities, specifically looking at the children that are under 5 and are unimmunized, and ensuring that they are reached with the immunization services. We'll be adopting geospatial innovations to identify or to map the locations, the children, the estimated numbers across the different locations, being able to map the service availability, and being able to identify strategic services that will ensure that those children are actually vaccinated. We'll also be adopting some innovative ethnopathic approaches, basically looking at HCD principles to understand both the supply and demand side barriers, and from those insights in this HCD process, be able to formulate strategic and context-specific interventions to assist us reach the children, of course, ultimately seeking to address some of those demand and supply side barriers. Humanitarian access is a key one for us because you have noted some areas have no access, others are partially accessible. So we'll continuously negotiate with the influencers, the actors in those areas, so that we can be able to be allowed to reach those communities and vaccinate the under-immunized children. We are looking at adopting a first and context-specific approach, having dynamic, different variations across the locations we're focusing on. We are adopting various strategies to deliver vaccination services to the communities. Some are commonly used, including, having campaign-like style in terms of reach the children, using innovative cold chain equipment to deliver cold chain services and vaccines to those communities, among others. We'll continuously generate evidence and learning so that we can be able to adapt and iterate our strategies in reaching those children, knowing that those contexts actually have not so much documented about those children. So we'll be seeking to fill in that gap and ensure that we are sharing those learnings with the other stakeholders. Partnership expertise is a key one. We are seeking to explore and leverage the expertise within the various partners, and they vary across different continuums. At the community level, we want to partner the communities because they play a critical role in identifying their own needs and even proposing some of the solutions. And now that we have received prototypes, insights from the HCD process, we'll be working with them to tailor strategies and interventions to meet their needs. We'll also be working with the various stakeholders and partners in those areas, including within the project, leveraging the expertise within the consortium partners across the different interventions so that we can maximize reach among those children and also have a greater impact. Next slide. Yes, so we have various partnerships. Of course, at the top is Gavi, the funder, and they're providing global leadership across various areas, immunization, and we really appreciate the support that they are providing. For Rescue, International Rescue Committee is leading in the area of leadership, supporting the establishment of monitoring evaluation systems within the project. And this will enable us, to continuously collect, analyze, and disseminate evidence that will assist us in improving programming in this area. And of course, working on this collaboratively with other consortium partners. We have a partner, ACASAS, who is bringing on board innovative digital solutions and platforms to improve decision-making in the areas of service delivery. We also have Reminder supporting data modeling and service optimization using geospatial technology, which I've already shared earlier. Then you have IOM supporting us with cross-border initiatives, including disbursement monitoring, surveillance, migration, and also, providing cross-border outreach services to reach those under-immunized children. I think Plus is the partner who is leading on the HCD component, just to use HCD principles to understand the supply-demand side barriers and ensuring that we have context-specific strategies to address some of those barriers. So we'll be exploring this to ensure that we maximize reach within the project. Next slide. Yeah, that was my last slide, just to share about the Gavi project within the Horn of Africa. Thank you.
Thank you so much, Paul. And we're having some comments coming in the chat box, like one that says that the people with the greatest social capital in communities, based on the respondents' work previously in Iraq, Sudan, Cambodia, are the community midwives, which is quite a key stakeholder that we could work with in reaching zero-dose children in these fragile contexts. So Paul, just a question, what are the unique cross-border or conflict contexts within the Horn of Africa that have posed the immunization challenges to immunization efforts by healthcare workers?
Yes, thank you. Thank you, Naomi. These areas are experiencing various extents or magnitudes of conflict across the countries. We have displacements as a result of those conflicts. There are refugees resulting from those, conflicts, and we also have areas that are really not having clear control, whether by government or other actors. As a result of these conflicts, we have seen disruptions in the delivery of services, health services in the areas. We have seen disruptions in the availability of healthcare workers. Some of them have been injured. We have seen disruptions in the supply systems, whether it's the basic services, whether it's the pharmaceuticals, vaccines, etc., generally overall essential supplies. And consequently, we have seen the communities themselves having what I would call, negative attitudes toward the services due to the many challenges they're experiencing in those areas. There could be mistrusts, there could be their doubts, etc. All these are compounding at the delivery of vaccination services, and consequently, we are having many children missing out on the vaccination services. So the project will be seeking to, identify the specific contexts, the specific challenges in the areas, and being able to customize interventions to address some of the barriers and ensure that we maximally reach the under-immunized children.
Mm-hmm. And there's one question from Mohammed Adan, and he asks that you please emphasize on human-centered design in addressing zero dose.
Yes, the human-centered design is specifically an approach, that has the human being at the center, that whichever intervention you are coming up with, it must be tailored to the needs of that person. So they will be seeking to understand some of the cultural, some of the supply side the barriers, some of the demand side barriers, and there could be anything, it could be the attitude of the healthcare workers, the supply systems, could be the knowledge of the users of the services, members of the community. So through these principles of HCT, and there's a systematic approach proposed by the project to just understand those behaviors, and consequently, we'll then be able to tailor interventions to meet those barriers and be able to encourage positive uptake of vaccination services within the communities that are going to implement in.
Thank you so much, Dr. Kisia, for your presentation and the responses to that question. I encourage you to continue sharing your questions and comments in the chat box, and the presenters will get to you shortly with responses. We now invite our final speaker for the day, that's Mr. Ahmed Arale.
Thank you so much, Naomi, for having me. My name is Ahmed Arale. As you have been told, we were called formerly Co-Group Polio Project, but now we have changed to Co-Group Partners Project because of taking on other diseases like Ebola, COVID-19, and Global Health Security Project. Next. Co-Group Polio Project, in a nutshell, is as was introduced by Lisa Helmy. We have worked in this sphere for the last 23 years. Recently, we received a Life Impact Award for the work by these NGOs and civic societies as far as contributing to polio eradication. And as you can see, it supports over 40 sub-grants to NGOs working in these target countries, primarily funded by USAID and also Bill and Melinda Gates Foundation. As you can see in the map there, that is the map of Horn of Africa. And all that color-coded spaces, each color represents an NGO working in those border areas. As you can see, they are all implementing at the border areas. And for sure, these are conflict-prone, insecure, whether there's castle hustling, whether it is for political reasons. These are porous, insecure borders that all these NGOs are implementing. And our project focuses on high-risk mobile populations that straddle these common borders of Horn of Africa. And our business has been identifying, tracking zero-dose children, defaulters, and also addressing geographic barriers. Next. addressing zero-dose children, who are these communities? Actually, the first that comes to mind is the nomadic pastoralists. These are mobile, transient communities. Their children are children on the move, and they are not served by the conventional health services. They are part of the missing. And they are, in Horn of Africa, like there are over 20 million nomadic pastoralist communities. The next category is security compromised and inaccessible communities. Communities that are under non-state actors. And this is where Kisia talked about access negotiation. You have to negotiate with these non-state actors so that you can reach them. Communities straddling borders. This is a very unique communities. And most times, these are homogeneous communities, especially in Horn of Africa. Kenya, Ethiopia, Somalia border, South Sudan, all of them, these are homogeneous communities. The borders are porous. People are on these borders are always underserved. There's minimal government infrastructure, and they really need attention. The other communities that you will find zero-dose children is urban informal settlement. The nature of these communities, daily wage earners, people who have no time really to even take their children to facility. Their needs, their livelihoods dictates that they are always working. The other category is undocumented migrants in urban areas. For political security reasons, these people cannot get services. They cannot get government services. So we have to get their children. The others are non-compliant allies in urban areas. Allies who generally will not want kids vaccinated. And many times when there are vaccinations, when there are campaigns, they are almost in gated communities and they will refuse. And sometimes we get unvaccinated children here. Seasonal farmers, like those herders who move with animals, they are farmers who do rainy season farming. They follow the rains. They move from one place to the other. They cross borders just to go and farm. The others are internally displaced persons from drought and natural calamities, security. So these communities are always out of their home and vulnerable. The photo you can see there is one of our outreach teams. And basically they will patrol these border areas and get nomads, help them, clean them, and also vaccinate their children. Next. Next slide, please. So what are the strategies to identify these zero-dose children that Core Group Partners Project has done over the years? One of them is most of the partners, the NGO partners who work in these areas really have earned the trust of communities. They have come to know, to understand them, and understanding this population movement is very important. And we collaborate with UNHCR, IOM, and the NGOs that attend to humanitarian services in these communities. So you have to understand their pattern. We identify zero-dose clusters, map and prioritize these clusters. We use, satellite mapping. You can see one of these maps is coming from our project region in Somalia, Bakol region, where you can easily map. And most of our community volunteers have smartphones, and they're able to geocode. The community volunteers are able to geocode where they found zero-dose. And that's how we get it. Mapping and profiling of internally displaced, pastoralists, refugees, cross-border population for the sake of immunization microplanning. We work with border health facilities so that the information, the microplanning information can help them track these communities. use of digital maps of border settlements, formal, informal crossing point, transit vaccination sites. We do this mapping so that we're better targeting where these religious leaders, women leaders, and local administrators, so that they can inform, so that they can
Hello,
access.
Ahmed.
Hello?
Oh, please proceed. We couldn't hear you earlier.
Can you hear me now? Hello?
Yes.
Yes, we can hear you now.
Yes, I said we have trained community mobilizers from the nomadic communities themselves. They help us in advising on the movements of these communities. They also mobilize them and link them to outreach services provided by the implementing partners. The other one is access negotiation with the non-state actors, and this is usually helped by the UN agencies. Next. Next slide, please. What are some of the best practices to reach these zero-dose children? Our community volunteers do newborn tracking. They have community and household registers where they take the record of all pregnant women, all newborns, they track them, and they do defaulter tracing, working with the health facility to ensure who are these children who have not come for vaccination. Also from the household registers they keep, they're able to know which child has not gotten vaccination. We also use neighborhood or care group model approach to reach households. These are neighborhood groups of close to 15 target population groups like pregnant women and mothers with under fives, led by lead mothers. They are trained and they work with the community mobilizers and community volunteers. And they also keep household registers. The other best practice is working with community action groups, women leaders, midwives, volunteers, religious leaders from all the communities we work, nomadic, IDPs and that, so that we are able to reach them. We also use trained and supervised community volunteers from nomadic pastoralists, IDPs and border areas to mobilize communities. And one of the key things is social mobilization committees at local level. In all areas we work, these committees are active and they help us mobilize these communities. As I said, we work with border health facilities to conduct monthly targeted outreach services, especially to communities that are underserved or nomadic. Cross-border interventions, we use special vaccination posts along the border areas and transit routes to vaccinate zero-dose children. Currently, as the drought is ravaging Horn of Africa, we are monitoring screening children at the border areas. We have heard that a lot of them are crossing to refugee camps. And what we find is that many of them are zero-dose children. So when we find them, we screen and vaccinate them. Next. We also, the implementing partners also deliver integrated program, especially One Health. Currently, we are working with the animal health departments to do zoonotic disease surveillance, which is very dear to nomadic communities. When they hear a veterinarian is part of the team, or there's going to be animal vaccination, they give that priority. And we use that to now get also the children. And nutrition in these areas, there are droughts, the humanitarian catastrophes are always there. So combining nutrition, wash, with vaccination is one thing we do. Moonlighting services for undocumented migrants. We have found that in urban areas, these undocumented migrants do not attend health facilities, government health facilities, even during the day. So many times they go to health facilities that are open at night, especially those in informal settlements. So this is where we send our outreach teams to work with those facilities to ensure that these children get vaccination. We conduct community dialogue, or in some places called community conversation on immunization at village level. And this is led by our community champions, the religious leaders, community volunteers. We also use hit and run vaccination in conflict areas, especially during when there's a lull in the fighting, and many times at the periphery or the border area of that area where we can pull children to come be vaccinated and they go back. We also support the Ministry of Health, do periodic intensification of routine immunization in these conflict and fragile areas. We also conduct immunization advocacy meetings at the local level with political, clan, and religious leaders. Next. What are the challenges? Working in this environment is very challenging. Of course, insecurity comes first. We also have the movement of these communities is very frequent. So keeping pace with them is not easy. Also, the cost of programming in these hard to reach areas is very high. Because of the insecurity, you will need sometimes to negotiate access. You need sometimes security escorts. The cost is very high. So programming, reaching these areas is very expensive. Also, many times there are competing priorities due to multiple outbreaks. Currently, we have cholera, measles outbreak in many parts of Horn of Africa. And the humanitarian situation is fragile in these fragile and cross-border areas. Accessibility of delivering vaccine in hard-to-reach areas due to limited geographical access and insecurity is also there. Also, poor health-seeking behavior of nomadic pastoralists. They rarely go to hospitals, they rarely go to health facilities to seek. So many times, services have to be taken to them. Next. What are the lessons learned for the many years we have worked in these areas? Engagement of communities and adequate involvement of religious as well as community action groups will enhance uptake of immunization services. The long-standing presence of NGOs in these remote areas have earned the trust of communities. Hence why we always engage NGOs and civic societies in these hard-to-reach areas. Robust partnerships enables cost effectiveness, efficiency, and sustainability of activities in this hard-to-reach and high-risk population. No one organization can do this work alone. So you need to partner with everybody, the government, UN agencies, all the civic societies, community action groups, really to work in this place. Next. Thank you so much. I think that is the end of my presentation. Questions?
Thank you. Thank you so much, Ahmed, for that. And we have two questions for you from the chat box. One, requesting for an explanation of what the hit and run type of vaccination is, and if you could also expound a bit about the context in urban informal settlements.
Thank you so much. I think in areas we work, especially South Sudan, where the security situation is volatile and conflicts happen anytime, we wait when things cool down and there's a lull in the fighting. There you can send in, especially when there are peace talks, you send in teams to do outreaches and you immediately pull. So that is what we meant by hit and run. The informal settlements, I can give you a clear example. Our project works in Nairobi City, in Kamukunji sub-county, where there are a lot of informal settlements, and there are a lot of migrants, undocumented migrants, who also live in these informal settlements. Hence, as much as it is in an urban area, it's in the city, and life in the informal settlements is quite different from others. And here you will get 0 doses. And this is where you will see there are clinics that are not registered by the government. They don't operate during the day, they operate at night. So hence, we find that many children access health facilities at night. Even their parents, who are Kenyans, who act their life during the day, have no time to take the children for facilities. So at night is where you get facilities that don't have immunization services are open and over services. And hence that is where our project partners with these facilities to go around and do outreach to these communities. Thank you.
Thank you so much, Ahmed. I'll now invite Victor.
I thank you, Naomi, and thank you, Ahmed, for this insightful presentation. I just wanted to highlight 3 points. I saw many comments and questions in the chat that are very interesting. I'm gonna take 3 and try to answer them. I think there was a comment from Mercy Barca. She was sharing her experience about 0-dose children residing close to health facilities. And I just want to make sure that the difference between children that live within the reach of health facilities are children that are being taken care by the national health systems and by other Gavi's funding levers, such as the EEF core, the 400 million that I mentioned in the presentation earlier. ZIP is very different. It only targets children that live beyond the reach of the national health systems. So if you find 0-dose children that live within the vicinity of health infrastructure, it doesn't tick the criteria for ZIP. It's complementary, so ZIP is only focusing on those children that live beyond, and for those children that live within, we have other funding levers. That was the first important distinction to make. The second comment, I think, was from Uni Damiza. She talked about sustainability, and it's a very important theme and a very important goal that needs to be context specific. If I give a concrete example, we'll have a conflict area where ZIP is only here to support immunization to those children in the short term. Once the conflict has been resolved, ZIP will move to other areas, and while the national health system and the government take over. In other areas, it's going to take longer. And that's why we emphasize the importance of having a strong monitoring and evaluation framework at the center of the project to be able to adapt the project and be very agile in how it's evolving. The third point, and I'll stop there, was coming from Dr. Shilpa Kumas on scaling up in Asia. I think that's a very good question, and that's connected to the learning. We have 3 years until 2025 to reach as many 0-dose children as possible. And we have 3 years to accumulate as many key learning as possible so that after the project finishes, we can scale up to other countries and unlock those 0-dose children. Over to you. Thank you.
Thank you, Victor, for that. I'll hand it to Lisa.
Yeah, thank you very much. And so, I would very much like to thank all of our presenters. I think the quality and also the participants. I've seen many, many great comments, especially, Ibrahim, and the most recent ones also. So thank you so much. We will be taking the questions, and we have been filtering them, and we will send them to the relevant presenter to actually respond. And then we will send those responses out with the webinar so that everyone will have their questions answered as much as they can. We realize that an hour and a half out of your busy day can be sometimes trying. So thank you so much. These learning opportunities are very important. I've seen that we have people from Nepal, from Korea, from all over Africa, throughout the world. So thank you so much for joining at different time zones. We have heard today about the REACH program, about the RAISE program, which are part of ZIP, Gavi's involvement with ZIP. And I think Victor just did a great job of explaining this very unique project. We also heard from Core Group Partners Project. And thank you very much, Ahmed, with the USAID investment over 23 years. I'm working on polio surveillance and immunization. So I thank you. As I mentioned, this video will be available. This webinar will be available, and we will send the link. And we also thank you for your patience with our little glitches with translation. There is more to come, and thank you for your time.
Thank you.
Very much. Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thank you.
Thank you
so much.
Thank you.
Thank you very much.
Thank you. Bye-bye.
Thank you so much, Mark.
Bye.
Thank you. Bye. Bye. Thank you. Wonderful.